Next speaker has over 40 years of healthcare interprofessional team experience in various settings serving older adults. She is a clinical social worker at Nebraska Medicine, Division of Geriatrics and Gerontology. Prior experience as an Alzheimer's Association care consultant, hospice social worker, a UNO Adjunct Faculty, LTC Corporate Consultant, sorry about that, for social work and recreation have all contributed to her understanding of the complex needs of older adults and how psychosocial issues impact the individual and the care partner. She has presented on a variety of subjects and topics focused on those living with dementia and their care partners. Ms. Hendricks has contributed to several aging population studies and publications, and I can attest for the fact that she's very passionate about contributing to the social work profession to create a workforce that will be ready to meet the growing demands of an aging population. So please help me welcome Diane.
Thank you so much. I think that's the beauty of coming in person sometimes, is that you get to network with the folks that you have been mentored by throughout the years, and certainly have taught me lessons along the way. So you would say, I've got the afternoon after lunch great spot, right? So I will take this approach from a psychosocial approach in terms of working with families that live with people that live with dementia, but also those families that are in that support system. I'm so appreciative of previous speakers because they've already set the foundation. You know the statistics, you know the caregivers, you know a little bit more about what the projections are, because here we are, one of the baby boomers. Okay, so lessons from the field. You're wondering, what kind of field would this be? Of course, the cornfield. I grew up in rural Nebraska, and detasseling was part of the work. I'd start the row, and it seemed like it would go on forever. But you had to do it with very detail and precision, because if you miss something, one supervisor is going to come along and say, you missed something. So you didn't get very far ahead of yourself. And I think that's one of the lessons that I've learned from older adults, that sometimes you just have to deal with what's right in front of you before you see the end. And then you start a new row, because life changes. Life is not linear, it's up and down. So lessons from the field. So we'll take a look at dementia, and again, I'm so grateful for the folks that have already set the foundation, because I've got a lot of material to cover, and if it's already been covered, I'm going to skip right over it. You can reference it in the PowerPoint if needed. But I want all of you to take away, what is your role as professionals, whether you're attorneys, social workers, or any other allied health folks. What do you take away from this, and what do you then take back to your practice? But how do we support those folks? And that's the driving force behind the conversation, is how do we support those folks along the way? So here we are. I should back it up. You didn't see that, right? No. Think of someone in your life that's an older adult and aging successfully. There are many folks that age successfully, and we consider that normal aging. So here's one. Celebrity time, right? Somebody else at ARP said we got some celebrity endorsements. Well, so I have a few along the way too. So Helen Mirren, normal aging, still working actor, 79 years old, has achieved a lot of recent accomplishments, a lot of certainly awards along the way, but also is what we would consider normal aging. And what does normal aging look like? Could look like that, because you see the physical appearances, don't you? She's not one to color her hair. She's one that keeps her hair looking the way it is. Her skin is beautiful, but as we age, that might change in normal aging. So we can certainly see the normal aging from a physical standpoint. But we don't always see what's happening within the brain. So this is normal aging. Let's kind of set the stage. We all had that experience of walking into the room and saying, oh, shoot. I had so many multitask things going on. What did I forget? And we would look at that as considered normal aging. How about, again, our the fact that, there are a lot of good things that go along with aging as well, and I want to get back to that. But judgment, when you go to Costco and you say you have 4 items you're going to get and you end up with 10. Maybe that's not the best judgment, but those things do happen. Or unfortunately, you may go to the casino thinking that you're going to pay just for lunch, but you leave with a $400 lunch. So again, a little bit of judgment issues, look back and say, could I have handled that differently? Occasionally lack of interest. Maybe you had interest along the way that you're saying, I really did enjoy doing those things in the past, but now vision has changed, normal aging has taken place, and maybe I don't have it much of as an engagement as I used to have. Visual spatial. This is where it becomes a little complicated, because visual spatial is something that we referred to earlier that really takes a lot of skill, day-to-day tasks such as driving, writing a check. All those things take that sense of this is where something is in space and time. But that can also be complicated as we're aging and adaptations are made. Word search. What was that word I was coming up with? Every once in a while, if you see me looking down at my notes, it's because I'm thinking about this and wondering if I've covered what I want to cover or using the right word on occasional times. And then an executive functioning that Dr. Wingle talked about, that plotting and planning. Getting here, what did it take? The fog, watch the weather, how do I pace myself to get here? That's plotting and planning. And sometimes that always doesn't come together as efficiently as we'd want. So one of the things that in the last 5 years, we just finished up in July, was a whole emphasis, and you'll see this nationwide if you look up GWEP, G-W-E-P. It's Geriatric Workforce Enhancement Program. And you'll see it was funded by NIH, and we had a grant that we with the Med Center Geriatric Division that focused on the 4 M's. And you'll say, as I'm aging, normal aging, the first thing that is important is to identify what matters. What matters to me? It's interesting because we were presenting this at a larger group of other folks that were working on this, and what matters happened to be one of the hardest questions to discern for physicians. Is that, did they take the time to understand really what matters? And so I'll give some examples as we're going along here as we talk more and more about what the brain does and doesn't do. But the medications, if we focus on these 4 areas, many people age very successfully. And if people in the workforce, meaning physicians, allied health, would focus on the 4 M's, a lot of times the needs of an older person are met. If they focus on what matters, medications, how my brain is thinking, and how I'm walking. Those are all aging syndromes and issues that come up. You know how it is. If one fall occurs, it can really change the trajectory of a frail older adult. So being mindful, and so come back to, coming back if you're working in geriatric practice or working with individuals, keep this in mind. What will help them age successfully. And then we come into the meditation part, and that's a little bit of an overview of talking a little bit about, we know what dementia is. I'm not going to get into the details of that. We know it's when the brain doesn't do its normal jobs, and we got to find out why. But everyone looks different. There's no average person with dementia. There's no average care partner that cares for the person with dementia. It's a person living with dementia, and all the roads look different. I'm not going to get into the types because I think we've done a nice job with setting the foundation. Thank you, Sadie. Thank you, Dr. Wingle. But this is kind of a quiz here, right? This is a famous person. Do you remember what type of dementia that he had?
Alzheimer's disease.
He did. Yeah. So he was one of the 50 to 75% of people with dementia. Is that this type of dementia, Alzheimer's disease, he had it at a later age, because if you remember, we talked about what's the biggest risk factor? It's age. So at age, he was 93 years old and 120 days when he disclosed and his family disclosed that this was going on. Anybody know who this is? Yay, yes, Margaret Thatcher. Right.
For United Kingdom.
Right. Age 87. Died with the second most common was vascular dementia, where the cells or where the blood vessels in the brain, and we see them in almost all aging brains, is the microvascular changes that come with, just wear and tear of the arteries in the brain. Blood pressure, cholesterol, those types of things start to wear and tear. But as it starts to wear and tear and it hits certain parts of the brain and the brain doesn't do its normal job, we tend to say this is more vascular related. And statistically, that's about 20 to 30% of the population. Alzheimer's being the most common, with vascular being the second. Okay, you ready for the next person? Yeah. Who's that? Yeah. So somebody corrected me the other day of the fact that he did die, and he had complications of Lewy body, but he died of a complication by suicide. So he died of suicide, but Lewy body dementia is more common than we think, 10 to 25%. People present with Parkinsonian types of symptoms where there's a little bit more of subcortical area where gait and balance is off, tremoring, but also marked with visual hallucinations that aren't necessarily scary but bothersome. And so he died of suicide. And who we have here, still living, Bruce Willis. He's frontal temporal dementia that Dr. Wingle talked about, where you'll see that executive functioning, decision making, plotting and planning, but also changes within that historical personality. Is that you'll begin to see, that if he was an outgoing person, maybe he's now more withdrawn. He's still living. One of the comments, and this is about 10 to 15%, but one of his family quotes was, "You don't hold on to what they were or what you want them to be, but who they are at this moment." And keep that in mind. I think it's a powerful quote because that kind of zeroes in on what matters to the individual in this moment. Not what they did, not what they're going to do and where things are going, but where they are now. You did well. Good. So in working with individuals that are starting to have changes within their brain, we'll sometimes separate minor cognitive impairment, minor neurological disorders versus major. So you'll hear that terminology oftentimes, especially with the newer language, and that's the jargon that I think we try to avoid when we're working with individuals that when their brain isn't doing their normal job. But minor would be an MCI where maybe memory is the only thing affected, but they're able to still function day to day with their daily living tasks. And then you don't look at a dementia until the person is having difficulty with what Dr. Wengel talked about, the IADLs. The housekeeping, the laundry, the medications, the driving, those types of things that we need to do independently to live. But in visiting with folks, the important takeaway to providers, all of you, is let's start to test early. If I think there's something going on, I want to know what it might be because it might be reversible. And the longer I wait, the longer it will be that I can reverse it. So if I've got a thyroid issue, B12 issue, if I've got a depression that hasn't been treated, those are even harder to reverse. So let's get on top of this really early. One of the things that has helped and prompted providers to get an earlier start is the fact that we have annual Medicare wellness. So if you're 65, it's a welcome to Medicare visit. Literally, it's called welcome to Medicare visit. But they do the clock draw on the memory and 3 recall word memory, and they also do a complete head-to-toe physical. So, and they look at mood, and more importantly, what matters to you? What medications are you taking? How is your mobility? So we cover those 4 M's. And it's really something that we're focusing a lot more in the academic setting when those residents come through in the rotation, even if it's just for a month. They're going to learn this because we've got to look at that whole person. Many times, at least over the years of working with, we did a grant with younger onset, so people under the age of 65. And you know how often they felt that they were delayed in the diagnosis, because no one would believe that I'm having these trouble at 65 or at 55. Did anyone take a look at my history? I was a boxer all my life. Had a lot of concussions. Or, you know, I have a dominantly inherited genetic disorder that would predispose me for younger onset. So take my concerns seriously no matter what age goes on. And then tell me what you're going to do about it. And Dr. Wingle covered a little bit about who works up an individual that's presenting. And at least in our clinic, it's really important when he mentioned the geriatric assessment program. Folks come to us for about 6 hours of that time. 2 of those hours are imaging. But the follow-up is about an hour and 15 minutes, and the patient is with the physician, and they are asked to, if they'd like, to invite their primary care partners. But the discussion, it's the patient appointment. They may have invited their family, but that conversation goes directly to that person that has been presented to our clinic to find out what's going on. Family is there to support, but that is still a physician visit with that patient. So telling the truth is so important at this piece of the juncture, so they know. We know the advantages of telling the truth and telling it early. You get a lot of good planning. And tell me what it means. Please don't use minor neurocognitive disorder versus major neurocognitive disorder. Do I have a dementia? More commonly, do I have Alzheimer's disease? Because that's what they know. And you know, when people are presenting in clinic and you get that information, you know, and you say, what questions do you have? They're way at the end of the stage of this disease, because they know what it looks like at the end of the disease, and they forget that that road is just starting, and that there's a lot of living to do in between time, and that they can stay independent a lot longer if they follow certainly lifestyle changes. So what do I need to do for my health to stay independent, and how long? And know that, you know, you've met one person, you can't compare my story to my cousin's story who had it, or my sibling, or my parent, or the person I visited as a neighbor. Everybody's progression of this disease looks different. And then talk to my other healthcare providers, right? So as providers, all of you I consider as providers, what do they need at this step of an early diagnosis after dementia is given? And things about, give me more information. You've got places, the Alzheimer's Association, Foundation, NIH. There's so much good information out there. The GWEP has that specific national collection of data, information that covers every aspect of how do I deal with this disease, what can I expect going forward. Don't forget, other things may come up. Even though my brain you can't see what's going on with my brain and why it's not working, but don't forget that I also have arthritis and it hurts when I get up. Or don't forget that if you don't check my blood work and we have a history of, you know, thyroid issues, that's important to me as well. Safety is going to be something that we'll continually talk about, but early stage, this is where you start addressing these issues. And you talk about, you know, where you meet them where they're at. Are they, you know, what do they understand about the disease and what do they need? Many of our folks still live alone in this earliest stage of the disease. So how do we do that safely? And some are still working. Sometimes it, you know, depending on the profession, what risks do you take by the people you serve? You know, there are going to be risks that plotting and planning, executive functioning are going to be impaired. And to be able to say, what are your risks and liability of continuing in that profession? Or when is it time to think about handing this over to someone else? Let's put some more, I think pictures have a better way of describing what might be going on from a psychosocial standpoint. So this is William Mullen. He was an artist in the United States, migrated during the pop culture time in the 60s over to Europe. Here he is, self-portrait. He's in his 30s at this point. I have to always make sure I reference this correctly. So this comes as he's actually 34 at this point, born in 1933 and died in 2005 at age 72. So you know probably what's coming, right? Yeah. So this is what's coming. He was diagnosed with the dementia. And this is where he was at earlier in the disease. The following slides are going to depict what goes on in the next 6 years over the time he is diagnosed to the time of his death. What do you see is going on? This is his self-portraits of himself. What do you see going on in his eyes, or what would you suspect if he was to say, I wonder what he was thinking when he drew that of himself? Any adjectives to throw out? What do you think he's feeling or thinking?
Hopeless.
Hopeless, yeah.
Suspicious.
Suspicious, yeah.
Maybe a little afraid.
Afraid, yeah.
Blank.
Yeah, blank. What's next? Yeah, and this is common in the earlier stage, and they ask these kind of questions. What's going on? And they go right to the end sometimes, don't they? Who will care for me when I can't care for myself? And more importantly for all of us, it's how do we keep the individual safe? And what's needed, a lot of times it's support of those IADLs we talked about. This is the time when we might say, you know, driving becomes a little bit more of a risk. Managing your finances become more of a risk. Medications, if you're on more than 5 and they change colors and they change size, it's kind of hard to keep organized. What can we do at this stage early on to start building that safety net in place? Here we are a little bit further into the disease. 2 years into the disease. And this is the part that, you know, the insight is still there. What's going on with me? You know, what am I going to need help with? You know, what is this really for sure? And there's not so much of the denial, as I always reframe it as more of a disbelief that this is happening. So kind of switch from denial, no, I don't have this, you know, because I rarely hear that hard, I don't have this, you've made a mistake. Or of, I can't believe this is really happening. And also from the family members, or the care partners, primary, whoever family is, right? Could be neighbor, could be it could be friend. So the emphasis in the early stages, what do they still can do and do well? And then we start to talk about a healthy lifestyle of 30 minutes of physical exercise a day. Start slow. Do gait and balance so you don't tip over or trip. Begin to think about, you know, being around other people. As we mentioned earlier, social engagement. This is a great place for this. You talk to people on the break. You get a chance to learn information. Those things should continue to keep us living independently for as long as we can. So here we are, moving along more in a more moderate stage. He's 3 years into the disease. This is where, you know, from a psychosocial standpoint, we look at historical personality, temperament being one of those characteristics that we really don't have control over. We're either a person who is even-tempered, kind of goes with the flow. We've got people who are happy-go-lucky, everything is fun, and any crisis that comes up, we can deal with it. Or somebody who's quick to temper. Those are innate, temperament is innate. We can't really change that. We can control it because environments put us in boxes to say, you go to work and you do this, and you gotta be even-tempered. Quick to temper doesn't always go over well. And happy-go-lucky may not be taken serious enough. So the structure provides us at work, you know, that temperament to be fluid and flexible. But when you go home, that's why it's so important with the collateral, is to find out what that temperament looked like. Because that will then predict. So somebody who's happy-go-lucky would be unusual in a moderate stage when this mood and behavior changes to see that they would be quick to anger unless there's something going on. And it's an extreme change. Or you've got a particular frontotemporal, we'll see sometimes, more impulsive, hurtful comments. But normally, and that's what people think, that this disease will somehow turn them into aggressive and violent folks. And you don't see that. We just don't see that. If people's safety is threatened or they don't know what's going on, yeah, they're defensive. We all are fight, or, we've got those instincts still there. But if historically they were never quick to temper, we don't look for it. And if we do look for it, then we figure out, if we see it, then we try to say, let's see what's going on. What happened before that aggressive behavior came about? What happened during that time, and how did it get followed up with? So mood does change at this point. This is usually when the talk comes to safety. Do we drive or not to drive? Moderate dementia folks are still driving. They may not be driving as successfully as they once did, like in new places on the interstate during rush hour. But some of them are still able to plot and plan and get to where they need to go because it's familiar. But this moderate stage might just see where that waxes and wanes, and this is where oftentimes referrals to occupational therapists at various hospitals that do a driving evaluation and a simulator and take you on the road, and you get your confidence back, or they may suggest modifications, or they would say, it's time to retire from driving. What are our options? That's usually what's going on in the more moderate stage. And what else is needed? Usually sometimes living alone becomes a little bit more complicated because those safety issues start to kick in, and we don't have enough of a safety net in place with medications or meals. Mood is problematic. Here's where, for attorneys, this is where physicians will often activate a power of attorney for health. The attorneys often still will work with us in helping the families determine whether it's important to activate the financial power of attorney at this point. But this is where long-term care kicks in. A lot of them, policies are 90-day exclusion. This might be the time to start getting that support and help going forward in the more moderate stage. So know your resources when you're supporting these individuals in a more moderate stage. Otherwise, keep in mind that most people are doing pretty well with a little bit of safety and support in those mild stages. And if you look at life expectancy, because that's a common question that people say, from diagnosis to death, it's about 5 to 7 years. But it's a bell curve, so you go 2 to 20. So, everybody's road is different. But this is the time to be looking at what's needed. Here we are now in the latter, getting more in the 4 years into the disease, and more of a severe stage of the dementia. This is when the round the clock is required. And people often say, how can we postpone that? All of us will die. Nobody's going to say that they're not. And I think when we think about any chronic disease, I did hospice for a number of years. Every chronic disease had mild, moderate, severe, and end. Every disease process does. So the goal in life is to keep you at the mild to moderate as long as you possibly can by doing some of these lifestyle changes. So we get to severe and end. If life expectancy is 5 to 7 years, maybe that's 1 to 2 years of that whole 5 to 7 years. And that's with every disease, that you're trying to maximize the independence for as long as you can by keeping engaged, so that the end of life, in severe stages, when you're requiring around-the-clock care, difficulty communicating, looking at long-term placement, discussing palliative care, that stage of life is short. And people say, I'll never get that way. I'll never meet that way. I'm planning to die in my recliner, right? 90% of us will leave this world gradually and slowly. 10% get to leave this world like we think we should. Go to bed and not get up in the morning. Or be in the hospital one day and be done with life and moving, dying. So 90%, you have to bring that back to people oftentimes. I can't tell you how often in the clinic I hear that. Well, I'm not there yet. But we're looking down the road. Your son that has brought you here today is happy to help you with transportation and getting you to your doctor's appointments, making sure you get meals. Well, he'll always be there, and I won't need that help. But when you do need that help, what will it look like? Well, I don't see myself getting there. Look to the son and said, if she needs help with bathing, dressing, grooming, no, I can't do that. So now we need to think about plan B, what happens to the person if something happens to that primary care partner. And this is where we should have had that conversation, surely at the beginning, where the person that is living with the disease in the mild to moderate stage has some self-determination to say, this is what I really want. And I really want to stay in my home for as long as I can, but if I don't have anybody to take care of me or a care partner and I have to bring that care in, and it's going to be around the clock, I have to budget 25 grand a month. I have to budget 25 grand a month for around the clock, and I can't even guarantee it's going to be reliable. So we've got to think about this. You've got to be planning how this will look for 90% of us going forward. So here he is. This is the last portrait of Mr. Ottmulen. It's his, at this point, if he's on palliative or hospice care, we would suspect that, he's not eating well, he's not able to communicate well. But in hospice, there's always a level of communication understanding, no matter what the disease process is, because people get a sense of, I'm safe, and I've got a sense of belonging, that somebody really kind of knows who I am and what my needs might be. So there's this trust of letting go. And you know what hospice looks like in terms of services and care. But at this stage, again, more vulnerability to infections, the weight loss, not being able to smile, not being able to have certain words or any words at all, maybe some eye contact, but at some level, there's always that connection. So you can see the comparison, right? Starting in 1996, 6 years later, how this has progressed to who he was. Never thought that would be the road he would be on. So again, we've got to look at assuring people that we have to get a dignified diagnosis and do it early. And I think we've come a long way, and I would hope to think that some of the GWEP with the Geriatric Workforce Enhancement Program that we've covered throughout the state and trained physicians that, they're catching this a little bit earlier. And then along with the Medicare guidelines of that annual wellness. But this is where we say we got to start supporting and start talking and planning about the safety. This is, we've got to make sure advanced directives are in place. Caregivers, I like this just because I don't know if you can even read that, but most caregivers don't sign up to be care partners, right? They're oftentimes by default. It depends on cultural preferences. It can be 24/7. I don't need to talk much about, because we did a nice job with Gina and Sadie and talking about, but Dr. Wengel and I would always say, if you don't take care of the care partner, you're going to have two patients, mostly. And here's why they apply. Sometimes they didn't apply. That's why I put a question mark. Sometimes it's default. And we know what it looks like to be successful. And so you got to be looking for that. And caregivers along the way, I appreciate the Medicaid for the TBI, the traumatic brain injury, that they do the caregiver training. But boy, I wasn't seeing that on the side of our older adults, and I hope that we can do that. The association pointed out that they certainly have a way for caregivers to learn things. Because some people, there are care partners that really enjoy being care partners. And others that struggle because they have to learn so many new things and don't know where to go. So affirming them as to you're doing well all the way along here. You're doing so many things right. How can I help you on this struggling piece? My top favorite community resources, right? We've already introduced some of those to you as time goes on, but people got to keep moving. And that's why the health and fitness centers that are catered toward people that are over 50, they're not doing the reps and doing the clunky machines, weights. They're doing the gentle ones that are used with air compression. They're not going to be jerky. They're not going to be bulking up. They want to just maintain so that they don't fall. And so adapting the environment. Boy, technology, thank goodness. We have come a long way. People put cameras up, they put sensors up, they put reminders, some of the apps you can call so-and-so, and they do it for, I don't want to plug any instruments, but you know what I'm talking about, and her name might be Al, anyway. They can do all those things. And so technology, and I'm excited in Nebraska because we do have a lot of innovative partnerships with medical, and our engineering is really good in Nebraska. And you get those engineers that are so excited about, yeah, my grandma had that same problem. She didn't turn off she never remembered to turn off the stove. And one time, well, those are things that get them going and excited about working with older adults, but also about their engineering. So, key takeaways, and we have some time yet? I don't even know where I'm at.
Yes, we have about 10 minutes.
Oh, good. That's pretty darn good. So take away some things, right? That, normal aging has a lot of promises in terms of, there's a lot of good things. We acquire a better vocabulary. We have wisdom and knowledge that we gather. We have a way of reflecting and keeping things calm. As my family member used to always say when the stress would come, she'd say, oh, there's always going to be something at this age. There'd be the big things, and then just be okay. Look where I've been and look where I've come. Because wisdom, understanding, resources are all advantages of being older. And then again, what are those resources in the community that you've been exposed to? Several of them today. And thank you for all the previous presenters. So a lot of references there. We can see clearer now, can't we? There's a clear path. And I think that this training certainly has given us a little bit clearer path. And I don't think they were detasseling that corn at all. Thank you for your time.
No questions? Okay, thank you
Great.
so much.
You're welcome.
And we will have oh, yes, sir?
Is there time?
Please.
Yes.
Please.
This may be an
No.
appropriately grim
No.
question, but
No.
are you familiar with any intersection between physician-assisted suicide and dementia?
We're seeing that topic obviously discussed all over the nation. I would say that that's not a discussion here in our state, right?
Right.
I think we have to look at that because I know our patients, when the diagnosis that they know is terminal and they're aware of it, the fear and the anxiety that goes with that, certainly you can't not ask them. And as people are aging, they will say, and you have to sort that out. And I think we overreact. When someone says, I've lived a good life and I know where this is heading and I don't see where you want, or need for anybody to be prolonging my life because you're not listening to me, what matters? What matters? And I think that that's where, with the older adults, at least this emphasis on geriatric medicine and what matters, and teaching physicians to drive their plan of care as to what matters. Yeah, where's the dignity? And maintaining the dignity and the quality of life and comfort. I think that discussion with that advanced care planning. The Nebraska has the physician-ordered life-sustaining treatment, the POST, that many hospices will use and or not in hospice. So it's clearly identifying what I want my life to look like, what I do and don't want. And we do have laws to protect that. Hastening life is not part of our state legislature. There are in some states. What they've learned, I think that's always an interesting. I've kind of moved out of that hospice arena, so I don't get as much. And if anybody wants to speak to that or comment.
Well, it's kind of a follow-up. We talked about the silver tsunami
Yeah, there's
and
many
the
of us.
$2,500 a month to be able to live in your
Yeah,
home.
25,000.
That's reliable.
25,000.
25,000. So
Yeah.
how would you assess Nebraska's available capacity to serve the silver tsunami in the next 15 years?
I'm going to defer that, Gina. Help me out here. I think everything was, people will call and say, what community do you think I should consider?
That's a good question.
And I don't ever give an opinion. I said everybody's different as to why they choose it. But, they're stretched. Those communities are stretched. And, I think that's, I'm impressed with the state plan, the Alzheimer's Association, along with a whole group of very invested folks, and the governor are looking at what does this plan for a state plan look like? How are we going to meet this need? So that's my only comment. If either of you want to comment more, I feel like I have to switch subjects on that good question. And I don't know if I have enough information.
And I'll just interject really quickly. One of the issues with this is from a legal standpoint, there's a lot of discussion nationwide about whether to include the dementias as a terminal illness or not, because so many of the rights of the terminally ill center around whether or not the person is quote-unquote terminally ill or in a persistent vegetative state, and the Alzheimer's, the failure to thrive type diseases are not included in that definition a lot of places. We have quite a bit of time, so if there's questions or discussion, please pursue it. When I told you had 10 minutes left, I was looking at the clock upside down, and apparently you had actually 15 minutes left at that point. So we have some extra time.
We could all go back to sex. I know I skipped some notes along the way because I was worried about going too long.
So feel free to do that.
No, I'm just kidding.
Any other questions?
Gina.
Yes.
I would just add, I think a piece of all of this is we have to relook at the way that we are, as we age and we move forward. Housing is a big, and I'm kind of going down a rabbit hole here, but the ways that we look at the different types of housing, or the non-traditional types of housing that we don't currently have in the state, our accessory dwelling units, the duplexes, the intergenerational care facilities, intergenerational apartments where we're bringing in nursing students to live in the same environment as an older person, and their rent is by helping that older generation, by helping take care of that. I think it's a shift in the mentality of what we had before versus where we're going. Again, as we said, that silver tsunami per se, we have it, it's here, it's
been here for a
taking
good
over.
5-10 years, and then COVID hit and
But
it messed things up too.
And again, it's that we can't look at the traditional ways that we've always looked at how we care for people and how we allow people to live. And again, like I said this morning, some of those, sometimes it's just a one little piece of technology in somebody's home that connects them with
Keeps
the
them
outside
independent.
world that allows them to stay in their home.
Yeah.
So again, kind of a rabbit hole, but to the whole concept, we have to rethink the way that we look at aging and look at it when we're younger versus when we were waiting too long. And now, again, we've known that we've had the baby boomers coming. They're here, they're wonderful. But we're also not doing justice to them because we're not changing the way that we accommodate their needs. Would be my thoughts.
Thank you. And I think, we see the disparity, right? There are actually some people that can afford $25,000 a month. But then it's also, the catch-22 there is, can you maintain the in-home care at that even? Do you have the continuity? Do you have the people there to do so? And, this conversation comes up a lot too, and it's kind of piggybacked off of the Medicaid discussion too, is that the whole idea of sheltering assets. And, 5-7 years look back, get on Medicaid, and state pays for my care. And then the comment that I consistently have with folks who are in that mindset of, I just transfer this amount of money, I don't need to give you details, but a large sum of money, at least 2 years of assisted living, to my son so that the state won't get it. And then they know the 5 to 7 year look back. And then I think the comment more so is those individuals don't have choices now.
We have a comment or a question.
Yeah, so choice, if you have resources, you have choice. So why would you shelter them? Why would you shelter them? When you know that's going to cost as much as it is to care? Go ahead.
So this is a question online it says, how can you approach the issue of dementia in persons with disabilities? And also, how can you provide accurate care to them?
Yeah, so I would say intellectual disabilities, I'm assuming. Yeah, and we know that there's a higher risk for individuals with intellectual disabilities to develop cognitive issues. You know, and I know the association does some training. You know, we have individuals that we care for in our clinic. Again, we see that individual progressing with memory changes and mood changes, just like we do anyone else that is aging without an intellectual disability. I think it goes back to, again, the education of if they're living in community, what is that community doing to adapt that environment so that they can stay independent and still do the things that they do enjoy doing, but maybe adapting it? You know, it takes education for people. You know, we have individuals who are trying to maintain, and they themselves are in their 90s, but they're caring for 60 and 70-year-old intellectually delayed, now with cognitive issue in the home, and trying to, but you approach it the same way. You still have to adapt. You just adapt it in a different way sometimes. But do you have the safe environment? Do you give that sense of belonging that I know that you used to help with this when you went to wherever you went to do some work. How can we adapt that same type of work now at the home situation or in the community situation by giving us all meaningful work to do that's helpful? Or what's important to me? You show me the dog and talk to me about the dog, I'm always going to light up because you know who I am, and I know you know that I belong with you because you know me and you keep me safe. So those two concepts, safety and a sense of belonging, doesn't matter where you live. Because if you have a sense of feel safe and a sense of belonging, that somebody knows you, and you adapt the environment and you build on the strengths, you know, we see that as all the way across the line. Yeah.
I have a question. Is there any training for people that are actually working in the penal system? So there's people that are aging that are incarcerated.
Yeah.
Are there anyone looking at those behavioral changes?
Do you know,
and
Sadie,
question?
if the folks that are incarcerated that, you know, because they have, my days, infirmary
Right.
care, and do you know if we're going into the systems, or do you know, Gina, or anybody know if we're going into the correctional systems?
They have,
Thank you.
Well, I don't work for Department of Corrections. They have a hospice unit.
Yeah, I remember, I
They have
knew
assisted
that.
living units. They have medical units. I'm, like, for example, when I do mine next, I
Mm-hmm.
met with a veteran at the reception and treatment center who will be going on hospice in the prison.
Yeah,
But
okay.
because it's not a terminal illness, it doesn't qualify for compassionate release.
But it seems to me, if we don't have that, that should be there. Because if aging is the biggest risk factor and our prison population is aging, the cognitive issues are going to be there.
They just announced something, but did anybody else hear what it was? Just in the news this week, they announced a new program in the penal system for people that have developed Alzheimer's and those kind of issues, but I can't remember what they said, if it was how they were going to take them out, where they were going to put them, and I think it was they were training people to go into the prison setting and provide care that was needed for people with dementia that were in prison, but I'm
Is this
sorry, I just don't
Nebraska?
have.
I was just gonna ask
It's
if
just
this is
Nebraska, and
Nebraska.
I just
I
heard
know.
it, I just wish I had enough clarity, but
They have a memory care unit.
I
at
don't.
Okay.
the
Well, this is
reception
something that was
Thank you.
brand new that they just got
Yes,
authorized, but
yes.
We
I
have
just
another
can't
question for
think
you,
what it
Diane.
was.
Great.
Right here.
This is what I like. Good conversation, please.
So I'm currently in the circumstance, I'm the primary caregiver for my mother who
Yeah.
has Lewy body dementia.
Yeah,
We live in a very rural area.
yeah.
I've been really fortunate. My mom has been to the Geriatrics Center. Dr. Wengel's actually one of her doctors. She also sees Dr. Merman. We
Yeah,
have great access to, I feel, like some of the best providers.
yeah,
But where we live, the struggle is that all of that great knowledge and the people who are in the
Yeah.
know, I don't find those people where we actually reside. And especially when it comes to trying to get caregivers
Yeah.
who are appropriately
Yeah.
trained to properly attend to my mom.
Yeah.
And it's, I actually wanted to have my mom in my home taking care of her. And I did do that for many, many months, 24/7.
Yeah.
I was doing that.
But
It's very, very hard
Yeah.
to find appropriate caregivers who can attend to hallucinations and delusions
Yeah, absolutely.
and all of that. And I'm trying to figure out, is there any plan to try to do some kind of grant funding or something educational where we
Yeah.
have amazing places here in Omaha that, the Geriatrics Center and the Gerontology Department,
Yeah.
that we're doing outreach to the rural areas because,
I
again,
agree.
it's a
I agree.
horrible struggle.
And I know we had hoped to emphasize in that rural area, but in the proposal that we were looking at to fund that, it didn't go through, but, it was amazing how because we were looking at public health, that's in every agencies on aging, and you've got mental and behavioral health, that there was a kind of a not working together real well.
Right.
But in terms of, narrowing it down then, so they don't overlap well, and they need to. We need to think about what that looks like to coordinate at least those 3 government agencies, because they are across the state. But, it comes back down to locally. What do I have in terms of area agency on aging? What do they have for information? I think about the Lewy body dementia group out of, that's with Julie Pavelka, that group. TAP in, that's Zoom as well.
Yeah.
So you get a little bit of the education piece of it. But I think you're right. I think that now that we're learning more about it, that how are we training our care partners and the professionals in the area? And I think that's, again, somewhat of a disconnect.
Yeah.
That who's responsible for what training. And assisted livings, of course, they have their healthcare organizations that do some good training, but those individual or informal caregivers are not. And I think that's part of the state plan, if I'm not mistaken.
Yeah, I feel like my mom's been in a black hole.
Yeah.
Because obviously, she's 84, we don't only have Lewy body, we've got other comorbidities.
Absolutely.
I keep running into the scenario where the closest so-called memory care, and it's this assisted living model,
Yeah.
right, is like 50 to 60 miles away.
Yeah.
And then I've found the skill sets in there, and that assisted living model can't properly attend.
No, I agree.
Then there are long-term
Just
care.
on what we would say, the average person, right? Whatever that means, but you're right.
And then you find skilled care facilities
Yeah.
that can properly attend to her physically, but their model and everything is kind of a nightmare for somebody with Lewy body dementia.
Yeah. Yeah.
Right?
Yeah,
And
there's-
you just can't find, and there are a number of those
Environmentally-
facilities
environmentally.
that have flat out refused because of the stigma with the diagnosis and the difficulty of the behavior.
And
The
this
difficulty
is
of the behaviors
right.
is about the environment.
Exactly,
not the person.
100%.
Yeah.
And like we've said, temperament, happy-go-lucky, that's all real.
Yeah.
So, yeah, and I think that we're in a dilemma, and I think we have to be looking at that as a state, and I'm hopeful that the governor will receive the plan that many people across the state have looked at, because you're right, we have to have a plan. What is the plan?
Yeah.
It's too late if we're starting now. We should have, this should have been going on quite some time. Yeah, and I think it did. I just don't know where all the priorities went. In 1989, Governor Ben Nelson put together a task force, and we all got together, and it was across the state. And we came together with the same idea.
Right.
And then you hand it off to the next person, and then now we're doing it again.
Yeah.
And it's like, we knew this was coming. Here we are. I don't know what we do.
Well, and I'll just speak to, my husband and I relocated back here when I knew something wasn't okay with my
Yeah.
mom. And it's been an eye-opener because I haven't lived rurally like that for a long time. And it's just, I couldn't my mother would have never been properly diagnosed. And if I didn't have the background that I had to know where to get her to get that, I mean, we would probably still be sitting there without proper diagnosis.
Yeah, and that's important because you want to try to see if you can reverse whatever it is, if it is reversible. You know, and then on the flip side of that, growing up rural and living where I'm living now, you know, and being a care partner in a rural setting as an adult, similar situation, there's so many informal care
There are.
roles there that, you know, I think the hospital social worker was helpful because she knows that Mrs., I won't say her name, but she would pick up my mom to take her down to the senior center for $1
Yeah.
or because of transportation needs. And so it becomes kind of word of mouth in a rural area, but there are a lot of people there that know that person to be able to say, let me step in, I know her, I've known that person all my life.
Yeah.
And so it becomes more of a, I want to be there.
Yeah.
So, you know, pros and cons to that, but I think you have to have a navigation. And I know a navigation of those resources no matter where they're at.
Yeah, and that's not easy.
You know.
I'm gonna be honest with you.
No, it isn't. It
Like,
isn't.
navigating the system is
Is,
gonna totally.
yeah, especially when you've got maybe 3 different systems, like
Or
I
have
just
to-
mentioned, are all addressing.
Or you have to drive 90 miles
Yeah.
to get to physicians that are truly informed about what you really
Yeah,
need.
yeah, you're right. Go ahead.
I would just like to add to all of that, that's valid, and I hear that all the time. I would say, just in my experience at the Alzheimer's Association, you know, I know we do what we can to host virtual programs. I know AARP does that same thing, and you know, it's a constant effort to recruiting volunteers so we can have those things in rural communities. But with this Alzheimer's state plan, that's where we're really starting to see these things come together. And so hopefully, you know, as time continues, right now it sort of feels to me as if we're all kind of working in silos, we're all doing great work. But as time goes on and this plan comes together, then hopefully it will be more of a cohesive effort. So the Alzheimer's Association, our home office is launching a program called GUIDE. It's an acronym, not sure what it stands for off the top of my head, but it's a care navigation system. And so they're launching it in 2 or 4 other states right now. It's not yet to Nebraska, but we hope to have a care navigation program set up here too.
Yeah, and I think, you know, disease specifics is one of my favorite areas to go. You know, the Lewy Body Association nationally has also a network of resources. But, you know, the Alzheimer's Association, because it's one of the largest types, yeah, they serve all dementias. And online resources are there. But I think, again, it's a coordination of understanding what I do like about the task forces they are looking at. I just named 3 government agencies across the state that may not be working or duplicating what we all can work together toward.
Well,
And
and the organizations, I mean, both Alzheimer's and the Lewy Body support, I mean, that's how I feel like I've been able to get better informed myself.
absolutely,
But then I'm oftentimes informing the doctor, not,
Yeah.
I mean, not
No, I
necess-
know, I
right,
know.
And it's the exhausting energy that goes into advocacy and almost a hypervigilance to protect
yeah,
her from people who don't know the intricacies of why there are a lot of meds you cannot give her.
Yeah,
why she-
absolutely.
You know,
Yeah.
like, and as a caregiver, there was enough stress in just caregiving, but it's unbelievably stressful when you have to be hypervigilant to protect her in different care
Yeah.
settings. Like if she goes into the hospital, I
Oh.
have to be involved to advocate because I
Yeah.
can't tell you the
And
things that
that's-
happened. Yeah,
and so, and that is so true.
yeah.
But you look at the number of people who have nobody.
No, I know, it scares me.
And I'm not saying that as, but that is, you know, who knows how to navigate these things?
No, I,
It used to be that health insurance was enough, and I often say a lot of times, I go, you know, the health insurance, you needed
Yeah.
health insurance, but I don't know why or what, there was the system, and similar things with my mother is, you have to have health insurance and you need a health advocate.
Yeah.
I mean, you have to have both anymore.
Yeah, and if you have long-term care insurance, you really better have.
Yeah.
some-
Yes, yes, it is.
Yeah, yes.
Yeah.
Thank you for
Oh,
the
no,
questions.
your comments were well heard and received by, and very, yeah, the empathy is there. We understand the confusion and the navigation, so thank you for sharing it. It puts more to the talk. Thank you.
We had a lot of really good discussions, and I remember talking to you on the phone.